today, I'm going to discuss about the role of endoscopic intervention in acute spine emergency and trauma. So in Malaysia, we are seeing rising incidents of emergencies such as acute Kaunar Equina syndrome as well as spine fractures in Malaysia due to rapid urbanizations and lifestyle changes. Whatever it is, the goals of operative treatment when it comes to these conditions remain the same. Decompression whenever there's a neurological deficit and instrumentation whenever there's a stability issue. It is always controversial as to which approach do we choose, open techniques versus minimal invasive endoscopic techniques. I believe that each of them have their own pros and cons, and then we will never come to a conclusion. We start debating it now. Eventually, at the end of the day, it is down to the preference and comfort of the surgeons versus the expectations and demand of the patients. Acute Kaunar Equina syndrome is a surgical emergency. The guidelines advocated emergency microdiscectomy as a gold standard where the approach involved unilateral laminotomy, medial facetectomy, as well as discectomy under the microscope. What about the role of endoscopic surgery? It remains controversial and many do not recommend due to its limited lesions, long operative time, and also the potentials of inadequate decompression. In 2023, Professor Hu Pang from Singapore advocated the use of monoportal endoscopic surgery or full endoscopic surgery to perform ULBD, bilateral decompression, and also endodiscectomy to achieve adequate decompression. These pictures was adopted from Professor Hu Pang's paper in 2023. As you can see here, he was using monoportal endoscopic surgery, performing ULBD bilateral decompression, exposing the lateral edge of thecal sac, and beautifully he performed an endodiscectomy. From here, I think that I could conclude that actually when it comes to overcoming complex cases, uniportal endoscopic technique is actually more than enough. However, in 2024, He et al. Proposed that when it comes to ULBD, biportal group as compared to uniportal group has advantage in terms of shorter operative time and also more efficient ipsilateral and contralateral decompression when they perform measurement on the pre and post-op CT scan, where the biportal group seems to have a larger dura sac expansion area as well as contralateral facetectomy angle. So right now, which one to choose now? If you have to treat cases using a monoportal or biportal techniques. At the end of the day, I believe that all endoscopic spine surgeons are just like snipers wishing to leave as minimal footprint as possible in our surgical treatment. One prefer to work alone and the other one prefer to bring along together with his portal. So end of the day, I think that it is still down to the surgeon's preference. And as for me, I think that if one is good, then two must be better. I would like to share with everyone regarding the cases that I encountered in my own private practice in a small hospital. This is a 40-year-old lady who presented to ED with a left-sided foot drop, sedus anesthesia, and also incontinence. Clinically, I diagnosed her to have Kaunar Equina syndrome. An MRI performed on emergency basis shows that there was a severe far down migrated disc of the L4-5, and we can see that there is also stenosis, severe stenosis over central and bilateral recesses. The reason why I opt for biportal techniques is because of the wide and clear endoscopic view, and we're using conventional instrument like Carrison to perform flavectomy. So this is in fact hybrid techniques that we could restore the classical principles, value, and also techniques of open surgery. But with the scope, you see that I can use a 30-degree scope. By twisting the scope, I can look at the corners more clearly. This is where I expose the ipsilateral nerve root. To create more space, I perform a medial facetectomy using osteotome. Again, the same instruments that we are familiar, exposing the extruded disc without much nerve root retractions and perform endodiscectomy, or you can call this, is actually a microdiscectomy techniques with nil to minimal disruptions of the neurostructures. So this is the post-op NRI, and I think that that is adequate or acceptable decompressions and discectomy. This video shows the clinical performance. You can see that there was a significant foot drop before the surgery, and there was a significant improvement of strength. As for the gait-wise, because of minimal incisions, we could mobilize swiftly. And 1 week when the patients turn back to the clinic, the patients have marked improvement of gait. This is another case of far migrated disc, which I treated endoscopically, and again, only unilateral laminotomy and discectomy, exactly like what is advocated in the guideline. No ULBD was performed. However, in those cases where the acute ulnar equinox syndrome is caused by central or lateral stenosis, ULBD is still necessary. And for those patients where only mild slippage, and in the event that patient is of advanced age, multiple comorbidity, I think that simple decompression still do wonders with acceptable clinical outcome. However, in those cases where there is a spondylolisthesis of higher grade, say for example in these pictures where the patient has a grade 2 spondylolisthesis, and also there's a concomitant stenosis. These patients had a right-sided claudication and also radiculopathy, and there's a gross instability shown in the dynamic X-ray. So in this case, I think that fusion is necessary. So for these patients, I come from the right side. So the technique is exactly same like open surgery. I'm identifying the right-sided facet. This is the IAP. This is the junction between the lamina and also the right IAP, using familiar instrument, osteotome, so that I can remove the bone and collect it and use it for bone graft for fusion later. So cranially, I use the osteotome to remove the IAP until the foraminal layer. So as you can see here, here is a natural detachment of the ligamentum flavum cranially. By taking out the IAP, I'm exposing the SAP. So the next target will be the pedicle, because I'm going for the safe triangle to perform discectomy later. So this is the pedicle, the roof, and also the medial edge of the pedicle. Once the pedicle is found, we can perform flavectomy. So using RF devices, for example, in this case, I can perform meticulous hemostasis. I can show all the neurostructures very clearly. It's also easy for beginner surgeons who have little experience in open surgery. This is the annulotomy. We can do a lot of procedure without retracting the nerve root because our clear visions under the scope. So this is the discectomy. All the steps are exactly same like conventional surgery. So again, I'm perform distraction of the D space using a shaver. So it is a technique that restores all the classical values and also techniques that we learn in conventional neurosurgery, and all those techniques are learned back in our med school. So again, with the scope, we can look behind our instrument, see how what happened to our nerve when we introduce our equipments. So the distinct difference between endoscopic fusion versus open fusion is the ability to visualize and also clear the end plate thoroughly. So you can see that the end plate is very clear, and we can work under a bloodless environment. And I think that this will eventually be translated into better fusion rate. At the same time, for those patients who have stenosis, we can also perform decompression. So this is, I'm removing the flavor away from the contralateral facet. So I can also, this is the contralateral nerve roots, and I'm removing the residual flavor using a Carrison. So sometimes if actually there's a stenosis, after we put in the cage, it can make worse the stenosis. So after satisfactory decompressions, I'm going back to my disk space and I can insert the cage under clear, direct, visual supervision. So this is the post-op X-ray showing correction of spondylolisthesis and restorations of the spinal alignment and small incisions, and the patients could mobilize fast after the surgery. Thoracolumbar burst fractures occur in high-energy trauma, and sometimes there was a bony retropulsion into the spinal canal causing compressions of the neural elements. The guidelines advocated surgical decompression whenever there is a neurological deficit and also instrumentation when there is an instability. So we have a 55-year-old gentleman who sustained an industrial fall, and this patient has a chance fractures of the L3, and you can see that there was a severe retropulsions of the posterior cortex with significant neurodecompression. Clinically, these patients presented with paraparesis with power of 2/5, incontinence with seded anesthesia. So rather than using open techniques to do open laminectomy, I use endoscopic instead so that there is a minimal disruption of the soft tissue, small scar. So the difference between laminectomy versus endoscopic ULBD is that over the cranial side of the lamina, there is no protections of the dura sac by the flavor. So the technique is actually to drill the bone until it's paper thin and removing using a blunt dissector. So under the scope, this is the amount of decompression we can achieve under the scope. And then this X-rays shows restorations of the lumbar lordosis with ligamentotexy and perp screw. And the coronal view of the X-ray shows the adequacy of the laminectomy using endoscopic techniques, small incisions, and the patients usually have minimal pain after the surgery, immediate mobilization, and 1 week when you come back for the clinic, there was a marked improvement of the gait. So this is the CT scans which shows the adequacy of laminectomy performed under endoscopic techniques. So we could expand the indications of bipolar surgery in burst fractures with neurocompressions fractures. So in certain cases, we can also do transpedicular reductions of the fractures. And because of the minimal incisions and pain after the procedure, the patients can mobilize fast. So we'll conclude that biportal surgery is an ideal solution for certain cases of spine trauma and emergency. It maintains the endoscopic minimal invasiveness, yet it restores the classical value of open surgery, and in fact, it is not just a continuation of the legacy, but augmentations of golden tradition of conventional surgery. Proper pre-op planning, water flow control, definition of surgical limit, anticipations of surgical step, meticulous hemostasis, adequate decompression minimizes complication. As we refine our skill and knowledge, I think that biportal surgery has the potential to revolutionize spine surgery and enhance patient care. Thank you.